Hello, and thank you for attending today. I am Matt Giannetti from Brigham and Women's Hospital in Boston, Massachusetts, and an assistant professor of medicine at Harvard Medical School, and I'm here to talk to you about indolent systemic mastocytosis. So in this video, we're going to talk specifically about the pathophysiology and differential diagnosis of the non-advanced variants of systemic mastocytosis, also known as SM. These are topics that you may haven't thought of about since med school. Probably most of you actually didn't even learn this in med school. But these are very close to my heart. And of course, the patients with systemic mastocytosis, they're close to their heart as well. So I think they're important, and let's move forward. All right, so mastocytosis is unique because the KIT D816V mutation is present in most patients with systemic mastocytosis. So there are not very many diseases that are driven explicitly by a singular mutation. But in mastocytosis, probably 90 to 95% of patients with this disease have the KIT D816V mutation. If you look here, you could see a picture or a schematic of the KIT mutation or of the KIT gene. So KIT is a receptor tyrosine kinase. And the cogent antigen is called stem cell factor. So in normal situations, stem cell factor will bind to the top of the KIT protein and initiate an intracellular signaling cascade. Now, in mastocytosis, the problem is that inside where the D816V mutation occurs, it causes the kinase to be constitutively active or always phosphorylating stuff. So in this case, it doesn't matter at all whether there is or is not stem cell factor. The signal is always on. So this results in abnormal mast cell signaling and a strong growth, maturation, and proliferation signal. This ultimately drives the pathophysiology of mastocytosis by causing mast cells to grow, proliferate, and mature in peripheral organs. So understanding that knowledge, how do we go about diagnosing systemic mastocytosis? So there's a couple of different things we can look at. I would focus your attention on the top left hand first. So blood work is always going to be the easiest, at least outside of clinical history, because blood is easy to access and we can draw tests kind of as needed. In blood, you're going to check CBC, differential, comprehensive metabolic panel, and BST stands for baseline serum tryptase, or just serum tryptase. Genetics on the top right are also very important. So KIT D816V is, as we talked about, is a driver mutation for the disease. This is also detectable in peripheral blood. We also look for tryptase genotype, also known as testing for hereditary alpha-tryptasemia, and a handful of other things as well. The other things that formalize the diagnosis of mastocytosis are the bottom two here, morphology and immunophenotype. These tests must be done on specific tissues of biopsy or specific organs that have been biopsied. So most commonly, we think of bone marrow biopsies. So once a patient has had a bone marrow biopsy, you can then stain that tissue and look for the morphology of mast cells. Do they have this kind of funny, flattened, spindle-shaped morphology? Do they express CD2? Do they express CD25? Do they form aggregates, etc.? So these combination of diagnostic tests, both one, raise suspicion for the disorder, and two, in terms of like the immunohistochemistry, can formally confirm the diagnosis of systemic mastocytosis. This is a kind of a small but super important point. So when we test for KIT D816V, particularly in peripheral blood, it is a rare kind of occurrence that you have a cell bearing the D816V. Mast cells grow and develop in the bone marrow, briefly travel through the blood, and then end up in the tissue. So the point being is you have very few mast cells circulating in peripheral blood. So if you're looking for a low-frequency event, you need to appropriately amplify in order to detect that low-frequency event. So this is the concept behind PCR. So all of you, regardless of your specialty, should always use a digital droplet PCR or another PCR-based modality to check for D816V. We have a handful of data showing the importance of this, and maybe even more importantly, highlighting that if you use next-generation sequencing or a non-PCR-based methodology, you will miss significant amounts of patients with D816V and therefore with systemic mastocytosis. So looking here in the last couple bullet points, 80% of patients who were D816V positive in Prospector had a tryptase less than 20. And so lowering the BST threshold to 11.5 increased sensitivity to 97.5 with 70.7% specificity. So again, use a PCR-based test. Super straightforward, super easy. Lots of labs offer it. Classifying subtypes. So this is important too. So once we've come up with a formal diagnosis of systemic mastocytosis, we then want to go back and look at the subtypes. So on the left here, you see bone marrow mastocytosis. This is really characterized exclusively by the absence of skin lesions. ISM, less than 2B findings with or without skin lesions. And then smoldering systemic mastocytosis is where you have more than 2B findings. So basically you have a lot of mast cells. I'm not going to belabor all the specific criteria, but the two most important ones that get me thinking smoldering mastocytosis is bone marrow with greater than 30% mast cell burden. So of the cells in the bone marrow, 30% or more are mast cells. That's wildly abnormal. And a serum tryptase greater than 200. The normal limit, again, is going to be about 11.5. C findings are signs of organ failure. So these are cytopenias, splenomegaly with hypersplenism, portal hypertension, really signs that the organs are not only impaired, but not functioning appropriately. The workflow here is 1, diagnose systemic mastocytosis using the major and minor criteria, and then 2, appropriately subtype systemic mastocytosis. Okay, within the differential diagnosis is hereditary alpha-tryptasemia. This is important too. I find the immunologists are pretty well versed with alpha-tryptasemia, but outside immunology, particularly dermatology, oncology, are not as well versed in this. So what is alpha-tryptasemia? Alpha-tryptasemia is a genetic trait. It is not a disease that is present in about 5 to 7% of the United States and Western European populations. It is basically a duplication or more, triplication, we've seen up to quintuplication, of the alpha tryptase gene at the TPS-AB1 locus. So basically what happens is instead of one alpha tryptase, you have 2 or 3 or 4, and there's a promoter that occurs that's co-inherited with the extra genes that basically tells the body to transcribe more tryptase. So the net result of this is you have a bunch more tryptase than you would otherwise have. Okay, so why does this matter at all for mastocytosis? Well, the minor criteria for systemic mastocytosis is tryptase greater than 20, so you will need to correct your tryptase values for alpha-tryptasemia. So correcting for HAT here, you take your baseline tryptase and you divide by 1 plus the extra numbers of TPS-AB1s. So if you have a duplication, for example, you would have 1 extra copy, so it would be 1 plus 1 equals 2. So you essentially just divide your tryptase in half. Super easy, and you can do it, in your head. Other differential diagnoses to consider. So there's kind of a lot here. Cardiology we see very commonly mimicking anaphylaxis. So hypotensive syncope is not always caused by anaphylaxis. It can be caused by arrhythmias. It can be caused by a whole host of other cardiac conditions. I would call out skin too. So people with the fixed cutaneous lesions are that's not going to be mistaken for urticaria or dermatitis. But many people who do not, who have a lot of urticaria or angioedema or other dermatitis can be confused. So keep that in mind. And then finally down here, monoclonal mast cell activation syndrome. This is a clonal disorder where people do not meet full criteria for ISM. So, in my book, this is like mini indolent systemic mastocytosis, but it does have a separate carve-out diagnosis if people do not meet full criteria, so it is important to be aware of. Okay, thank you for joining me today for this brief presentation regarding the diagnosis of systemic mastocytosis. I hope you found this video useful as a clinician, or even if you're a patient looking for more information about your disease. If you want a more in-depth look at non-advanced systemic mastocytosis, we have a separate CME accredited 60-minute webinar, which can be found at exchangecme.com.